Hello, my name is Mary Massery. I'm a physical therapist, and I'll be presenting a lecture today on posture and breathing, linking them together in post-COVID-19. This is part of a lecture series called the PACER Project, Post-Acute COVID-19 Exercise and Rehabilitation Project, sponsored by the American Physical Therapy Association and in conjunction with the Cardiopulmonary and Vascular section of the APTA. The PACER project is a series intended to assist PTs in anticipating possible therapeutic needs of the COVID-19 survivor with moderate to severe symptoms. My lecture will focus on the post-acute COVID patient who is medically stable but surprisingly not returning quickly to their pre-morbid health status and/or pre-morbid activity level. Disclaimer, the course is intended for educational purposes but does not replace mentorship or consultation with a more experienced cardiopulmonary or acute care colleague. The content is current at the time of dissemination. However, we all must realize that the evidence and science on COVID-19 is evolving and information may change very rapidly. Again, my name is Mary Massery. I'm a clinical specialist focusing in the area of breathing dysfunction and postural control, and I'll have you read my bio at a later time. I have no conflicts to report. The objectives. I want to present a brief overview of COVID-19 and indicate how the disease might have adversely affected physical function in the post-acute phase. I'm going to suggest early, I'm also going to suggest late PT rehab ideas, looking at possible multi-system reactions to the disease, so looking at the cardiopulmonary, musculoskeletal, neuromuscular, integumentary, and internal organ systems, and then demonstrate how breathing and moving can intentionally be used together to improve breathing efficiency, especially for COVID survivors who likely have residual pulmonary problems and fatigue secondary to the moderate and severe level of the disease. What do we know so far? This will be a very brief overview. COVID-19 is a very contagious, serious novel virus that causes marked respiratory compromise in severe cases, sometimes requiring mechanical ventilation and sometimes resulting in death. The primary sequence of COVID-19 attacks is that it starts at the ACE2 enzyme receptors, which help to regulate blood pressure, potentially creating hemodynamic instability. The ACE2 is located on the type 2 pneumocytes in the lungs, so the virus may also disrupt surfactant production, which will impair alveolar gas exchange, causing dyspnea, otherwise known as shortness of breath. This can prompt an immune response that overreacts, causing hyperinflation, a cytokine storm, and increasing the risk of death. I'll suggest that you look at Steve Tepper's lecture for a detailed presentation on physiology and pathophysiology. So what do we know about possible long-term deficits? Not much. The virus is novel, so we're making educated guesses as to the survivor's needs in rehabilitation. So I'm going to propose some ideas for acute rehab settings based on COVID symptoms and pathologies, and then extrapolate some ideas. What might be some long-term problems that may be seen later in home care or school or outpatient settings long after the disease has resolved? These suggestions will change and evolve, obviously, as we all learn more about the virus. So what can we deduce will be the rehab concerns for moderate to severe COVID survivors? I'm going to present 4 of them. 1, acute COVID symptoms last a long time, often for 3 weeks or more. So extreme deconditioning would be expected due to prolonged sickness. And for some patients, it will also be due to ICU acquired weakness. This will affect the patient's ADLs and recreational activities, and would be expected to be worse for those who have the ICU acquired weakness. Prior studies show low-intensity training for 6 to 8 weeks and interval training can be effective PT approaches. Diaphragm weakness occurs quickly in the ICU, so deconditioning is mechanical as well as physiologic. The practitioners may want to consider using ultrasound of the diaphragm as an effective means to determine the extent of weakness and timing of the diaphragm activation. However, this does require skill of the trained therapist and/or other professionals. The second deducible concern, the distal lung segments are damaged by the virus, so fibrosis or scarring of the lungs may occur. This can possibly result in a tight rib cage, which can impair shoulder range of motion and shoulder mechanics, and can impair trunk mobility, as well as obviously impairing lung function. Over-recruitment of the accessory muscles due to shortness of breath may also occur because of the damage to the alveoli. This can possibly result in pain such as headaches and neck or shoulder pain because the muscles are in overuse, and obviously also create impairment to endurance. The third deducible concern, increased work of breathing may present a conflict between breathing and postural control. This can lead to impaired balance, as the diaphragm is simultaneously a respiratory muscle and a postural muscle. When forced to choose, the diaphragm will choose breathing over postural stabilization, and that can result in a balance impairment. It can also result in an impairment in distal force production. Proximal trunk pressures, intrathoracic and intra-abdominal pressures, are necessary to produce maximal arm and leg force. If the body is working hard at breathing, it may not be working hard at producing the correct forces necessary to generate force through the limbs. There may also be an increase in gastroesophageal reflux disease, otherwise known as GERD, because the diaphragm is also a significant anti-reflux muscle. So weakness in the diaphragm would predispose patients to reflux later. And the last deducible concern that I would present is for the patients who are on mechanical ventilation. The endotracheal tubes are going to go right between the vocal folds, and this can cause stretch weakness and/or soreness of those vocal folds. The vocal folds are critical to the generation of core trunk pressures, so weakness of those folds could cause a decrease in balance and distal limb force production. So we're seeing an overlap in dysfunction when you have the diaphragm affected as well as the vocal folds. So why are these concerns possible long-term problems for the moderate to severe COVID survivor? It's all about pressure. Successful coordination of postural stability and respiratory mechanics depends on how well that patient with motor impairments can generate trunk pressures, regulate trunk pressures, and maintain trunk pressures. And they have to be able to successfully do that in both the thoracic and abdominal cavities. So if we take a look back at the entire trunk, and we look at it from a can of Coke perspective, we see that when that can is closed, we have positive pressure from within the can that is greater than the forces acting upon it. So the pressure creates functional strength to an otherwise weak external structure. If we put the diaphragm in the center, we recognize that the diaphragm separates the thoracic cavity from the abdominal cavity, and thus is a major trunk pressure regulator. So when that diaphragm is weak or dysfunctional and the timing is off, it can make it difficult for the body to generate, regulate, and maintain pressures in the entire trunk. If we add the two external valves, the vocal folds at top and the pelvic floor in the bottom, we see that the top of the can is actually directly related to the function of the bottom of the can. So these patients who have problems in the lungs affecting the diaphragm, perhaps also mechanical ventilation affecting the function of the vocal folds, could wind up with something as distal as pelvic floor dysfunction expressed as stress incontinence. So all of the pressure regulators together help us to have function for upright trunk control, as well as ability to voice, to breathe, and to have continence. So COVID survivors. Patients may have been able to generate, regulate, and maintain proximal pressures efficiently for breathing and postural control before COVID, but they may now need PT to help regain those skills. Treatment should focus on breathing and postural stability, not one or the other. We need to look multi-system. Is the presenting symptoms, such as shoulder range of motion limitation, or neck pain, or balance impairments, or less strength in the legs, truly coming from the musculoskeletal system, or is it coming from the severe respiratory issues and presenting later as a musculoskeletal consequence? The acute phase has subsided. If physical problems remain, where might they be coming from? So if you can, stand up, and I want you to do this simple test. We're going to look at how the shoulders are linked to the trunk and to breathing. So when you're standing up, I want you to stand with your arms by your side, your elbows are straight, your thumbs are forward. Raise your arms straight up into the air. Did you inhale, exhale, or have no change? What happened spontaneously? All of you should have found that when you raised your arms up, elbows straight, arms close into the air, as you see with Deborah, that you automatically inhaled because you linked your shoulders to your trunk. And when you did that, you actually dropped pleural pressures in your lungs, creating an expanse of those lungs, and you automatically inhaled with shoulder flexion. Let's do it again, only this time we're going to use lazy elbows. So if you look like Tom here on the right, using lazy elbows, raise your arms up. And again, notice whether you spontaneously inhale, exhale, or there's no change. For the vast majority of you, you're going to feel there is no change. You neither inhaled nor exhaled. And that's because with the elbows bent, you didn't link, physiologically, you did not link your upper extremity to your trunk. So you didn't change pleural pressures because you didn't expand your rib cage or spine, and thus there was no drive for you to inhale or exhale. This is potentially what we will see with the patients post-COVID. If their rib cage gets tight, if there is scarring in the lungs preventing the ribs from moving, you might see the motor impairment expressed far more distally. Say shoulder dysfunction, wrist dysfunction, etc. So make sure you're looking back to see what happened with their COVID presentation. So what are the body systems that do influence postural control? With PTs, we know it's musculoskeletal and neuromuscular as the primary body systems involved in postural control. The less obvious systems, though, include the cardiovascular pulmonary system, which is the primary system involved in the COVID virus, as well as integument and the internal organs, especially gastrointestinal. So physical symptoms. If your patients are presenting with physical symptoms that they can't explain from an accident or other logical disease, I want to make sure that you're looking for underlying connections to COVID if you know they are a COVID survivor. It's not likely that our patients who had a mild case of COVID would present with physical impairments, so we're looking more likely at the patients with moderate to severe COVID. The patients may not even recognize the connection, so you have to ask them about their COVID experience and determine if the current physical impairments might be related to breathing deficits. Possible physical problems per body system. So let's take a look at this. What might happen after moderate to severe COVID? From a musculoskeletal standpoint, the rib cage, the spine, the shoulders, or the pelvis may have range of motion limitations, and they may need manual therapy. They may develop pain, neck, shoulders, headaches due to excessive accessory muscle use during the sickness. You've got to find the root of the pain, not just treating the pain, but asking, why do I see that pain? They may also develop pain in the low back, secondary to diaphragm dysfunction. Is it just weakness, perhaps? And or is it presenting a conflict of the diaphragm between its role as a spinal stabilizer and its priority right now to support breathing. If it's focused so much on breathing, it may not be able to share that role effectively as a postural stabilizer. Neuromuscular. We may see a decrease in strength, poor physiologic health, deconditioning, and importantly, poor proximal pressure support, or what we would call a poor core activation, may result in functional weakness in the limb muscles. They would need proximal pressure training with breathing as well as general strengthening. We may see a decrease in balance. The diaphragm and all of the respiratory muscles play dual roles in breathing and postural control. With an increased demand for respiratory duties, these muscles aren't available to work as trunk stabilizers. Hence, balance suffers. Work on your breathing to work on balance. Neuromuscular. Continued. Add ventilatory strategies. Match the breathing phase to the trunk movements of what you're doing to improve the efficiency of breathing and movement together. And I'll give you some specific tips at the end of this lecture. Consider doing dynamic neuromuscular electrical stimulation for very weak muscles or for poor activation or timing of those muscles. Cardiopulmonary system. If lung secretions are a problem, you're going to add airway clearance techniques, and those are covered in a different lecture. You may see inefficiency of breathing mechanics. They're going to need neuromotor retraining at rest and with activities. Very specifically, they may need diaphragm activation and strengthening. You may want to consider inspiratory muscle training for endurance, like with the breather, which is pictured to the right, and I do not have any financial ties to this product. Integument system. They could wind up with fascial tightness across the chest that could impede chest expansion and shoulder motion in an upright postural alignment. Is the postural impairment musculoskeletal, or could it be fascial? If it's fascial, add myofascial manual therapy. You're also going to check for skin breakdown due to prolonged bed rest. Internal organ system, especially looking at the gastrointestinal system. The diaphragm is an essential part of the gastric junction, working as a force couplet with the lower esophageal sphincter, which you can see right in the green circle, and together they help to prevent reflux. The diaphragm is almost 50% of the reason that you don't reflux. So if the diaphragm is weak, the risk of reflux increases. Reflux will impede health and pain, impedes voluntary trunk flexion. So PTs really do need to address reflux. Diaphragm training and strengthening may help to reduce this. You're probably thinking this right now. Give us something simple to help improve efficiency of breathing and movement right away. So we're going to use the KISS principle. Look at that, a typo. Well, I got to continue on, got to get this out. Keep it simple, stupid. Just change that D to a K. So we're going to look at ventilatory strategies. What are ventilatory strategies? I call it the intentional pairing of inhalation and exhalation patterns with movement in order to enhance the overall motor task. The purpose is to integrate the body systems into fluid and efficient movements from basic bed mobility, which would be certainly in the acute and immediate post-acute phase of COVID, and all the way back to recreational activities and up to professional sport. So this chart is probably going to be very helpful for you. I actually highlighted one track on the orange just so we could go through that together. So look up at the top. Let's say the movement is I'm reaching up to the kitchen cabinet, or I'm reaching up to serve a tennis ball. Anything reaching those arms up above 90 degrees. I'm going to look first at the thoracic spine. What does the thoracic spine need to do for that task? If I'm reaching up to the cabinet, I need trunk extension, not flexion. The matching respiratory phase, which is the second row, would automatically be associated with inhalation, because with trunk extension, I expand the ribs, which pulls on the pleural pressure, dropping the pleura, dropping the pleural pressure, and causing negative pressure within the lungs, causing them to expand and inhale. So trunk extension automatically goes with inhalation. Look at row 3. What is the type of muscle contraction needed for that particular activity? We're still over on the right-hand side, and in this case, raising my arm up to get something out of the kitchen cabinet would require thoracic spine extension. It would require me to inhale automatically because of the drop in pleural pressures, and the movement of my shoulder muscles would be concentric as well as my respiratory muscles. Let's look at the 4th row. I would then match that movement with a specific respiratory response. So if I'm looking, going over to the right-hand side, if I'm looking at trunk extension, that means I'm going to be inhaling. I would prefer to use an upper chest inspiratory effort so that I can maximize shoulder flexion with the lift of the chest. It's trunk extension and more fast twitch muscle fibers. The matching visual strategy on line 1, 2, 3, 4, 5 would be eyes up, and this is a natural pattern that we learn in the first year of life. So eyes up is very heavily associated with inhalation. If my patients are very weak, post-COVID, early stage of rehab, I'm going to be using those eyes very specifically to help to improve the respiratory response. Line 6, matching audible strategy. This is something that patients taught me years and years ago in clinical practice. So going over to the right, if I want my patient to be able to extend their spine, take that breath in, raise that arm up, and get a glass out of the kitchen cabinet, I'm going to use a louder, higher pitch, and faster cadence voice. The louder voice is actually saying to the patient, I demand a greater response, which in effect tells them to recruit more accessory muscles. My higher pitch is telling them to lift their chin just slightly in order to produce a higher pitch noise, which helps to facilitate a full trunk extension response. And the faster cadence in my voice helps to facilitate a greater recruitment of the fast twitch fibers, which is what I want if I want upper chest expansion. So if we come all the way down to the bottom and look at what strategies we use, simple strategies that cost nothing, that can be used from very early rehab and right through to regaining that tennis serve, and that is that if I want upper chest inhalation, inspiration, I'm going to use trunk extension, I'm going to use a big breath, I'm going to use concentric maneuvers, upper chest breathing strategy, eyes up, louder, faster, higher pitch voice, and/or sharp audible cues. So let's take one quick look at a patient who is not a COVID survivor because we don't have many of them yet. I took one of my patients, his name is Ryan. I treat mostly pediatric and young adults. He's a 16-year-old healthy male. He has a congenital pectus excavatum, which means that his chest is concave at the base of the sternum, and he has secondary postural consequences. This is what Ryan looked like when I first evaluated him. So asking him to go over to the door, stand up straight. This was this 16-year-old's posture. This is not an 86-year-old. This is a 16-year-old. And his pectus excavatum in the front has literally pulled his whole body down into the xiphoid process and making him look like a much older body. Asking him to lift his shoulders, you're going to see the lack of thoracic extension, the over-reliance on lumbar extension or lumbar lordosis. You're going to see that his chest hasn't moved at all, and you'll see his head is pulled forward and his elbows are bent. Even though he's 16, because he had such limited mobility in his rib cage, because of his pectus excavatum, it limited so many other aspects of his postural alignment and postural function within his shoulders. He was really predisposed to having pain, perhaps in his shoulders, also could have been head or neck, or very likely his low back. Our COVID survivors may present like Ryan, only they are likely to be older. I want you to see what can happen. Obviously, with the 16-year-old who has underlying health is going to have a more dramatic potential outcome than we would see in an 86-year-old. But I want you to see what happens when you really focus multi-system. You can see Ryan in his pre-treatment. This was his initial evaluation. And then Ryan, 6 months later, after about 20 PT visits, with dramatic change in his alignment and his awareness of postural control. And then because Ryan did have an adverse effect on his heart because his pectus was so deep, they did have to do surgery. This is what he looked like post-surgical. So this is over about a year and a half, maybe not quite a year and a half, quite dramatic. When we look at shoulder flexion, you can see again where he's very likely to develop chronic pain secondary to poor postural alignment. This is after 6 months of PT only, dramatic improvement in his rib cage mobility, his ability to activate all of his core muscles. That means way beyond just the stomach, from the pelvic floor all the way up through the diaphragm, into the intercostals, and up into the vocal folds. Look at how beautiful his shoulder range of motion is. And my colleague Linda Ross and I never actually needed to treat his shoulders. Still needs more thoracic extension, but I'm quite happy with where he had gotten in 6 months. He did need surgery, as I mentioned before. This is what he looks like after surgery. Incredible changes in a year and a half that gave him much greater breath control, much greater lung volume, and allowed him to participate more in physical activities. When you look at the pectus itself, you can see where his body was pulled in, not only at the sternum, but where the rest of his body appeared to be pulling into that black hole. This is post-treatment, and don't be deceived here. It looks like his pectus is worse, but if I actually take away the pectus itself, you'll see the reason his pectus looked worse is because everything else was better. That actually helped the surgeon to know that PT could only go so far, and that was the final signal that he did need to have his pectus repaired surgically to relieve the pressure on his heart. And this is what he looked like after his surgery. Still going to notice that there's a little kind of soft hollowing out of his anterior chest wall, and that's because his PT started so late. He was already well into puberty by the time we started PT. The reason he didn't have PT before, you'll probably ask, is because all of the doctors before, pediatricians, etc., said this was just a cosmetic problem. His mother sought and sought answers until she finally found them at our pectus excavatum clinic. So looking at Ryan's treatment progression using a multi-system approach, since we said we were going to be looking multi-system, is for Ryan, first we had to look at his internal organs. He didn't have any problems. We had to rule out reflux due to pressure on the gastric junction from the pectus and from higher pressure differential between intrathoracic pressure and intra-abdominal pressure. That was not his problem. He did not need any PT interventions for internal organs. The second thing we really focused on was integument. He did have restricted skin and connective tissue on his anterior chest wall, and we used a lot of myofascial techniques. 3, musculoskeletal. He lacked mobility throughout his entire trunk, rib cage, spine, shoulder, and pelvis. The pectus pulled everything forward into its black hole, which created marked secondary postural impairments. Manual therapy was a significant focus of his treatment, primarily on the ribs, on the spine, and on the pelvis. Actually, we didn't need to treat his shoulders. His shoulders went into a normal position when the rest of his trunk was corrected. Cardiopulmonary. He had healthy lungs. He didn't have asthma. He did not have COVID, but he did need increased expansion in the mid-chest so that he could take a deeper breath. We focused on the intercostal muscles to stabilize his ribs and then to be able to rotate his trunk for gait and balance, as well as obviously to take that deeper breath. Last and most importantly for Ryan was neuromuscular. He had wonderful gains in trunk range of motion of his spine and of his rib cage, but neuromotor retraining to regain his ability, not regain, to actually learn how to breathe and move was what really took the focus of his program. So neuromotor retraining to effectively focus on coordinating breathing, moving, and dynamic stabilization with all activities. So thinking of the same idea for our COVID survivors, internal organs, we want to rule out, do they have reflux secondary to altered breathing mechanics? We want to rule out, do they have reflux due to a weak diaphragm? Remember that the diaphragm is a major anti-reflux muscle. Integument, we want to rule out restricted skin or connective tissue. We want to rule out skin breakdowns from prolonged bed rest. Musculoskeletal, because of that potential for fibrosis in the lungs and the fact that the inside can affect the outside, we may see restrictions around the chest and the spine, and we may wind up seeing more distal restrictions develop secondary to those tightnesses. Cardiopulmonary, do they have true lung impairments? Is the impairment itself from mechanically compromised breathing mechanics or just the physiology of COVID? We need to rule out the need for airway clearance techniques. That is also covered in another PACER lecture. And we have to look at endurance. We may want to add an inspiratory muscle trainer early in rehab. I had suggested the breather. You could use whatever inspiratory muscle trainer that you have available. You want to start with very low resistance in sitting, building up to 15 minutes at a higher resistance level, and then working into higher postures, working to standing, maybe walking, maybe for some of your patients, even running. Neuromuscular, you want to rule out inadequate coordination of breathing with movement. You're looking at core activation, balance, strength, etc. And I want you to consider doing neuromuscular electrical stimulation for weak muscles, especially for those patients with prolonged bed rest. Telehealth. COVID rehab programs could be started with telehealth if social distancing is still necessary. Otherwise, if you can see the patient directly, that would obviously be more ideal. Monitoring vitals and other tests in rehab are going to be covered in another PACER lecture. So what are some of the take-home messages from this lecture? If I can get one point across, it's that all the trunk muscles work together to support postural stability, as well as to provide simultaneous support for breathing, for posture, for balance, for lymph force production, for continence, for voicing, and so much more. Moderate to severe COVID survivors are at risk for physical deficits beyond the lungs because the respiratory system interacts with multiple body systems. PT rehab assessment should rule out potential adverse sequelae across body systems, both immediately post-acute COVID-19 as well as long-term post-acute COVID-19. Research will change our understanding of this virus, but this will be a good beginning. I gave you 5 significant COVID references for you to take a look at. You can pause this slide later to look. I also provided 5 non-COVID references, and again, you can pause this slide and look at it later. I hope this material was helpful for my colleagues, my physical therapy friends and colleagues who may be seeing our COVID survivors, and I wish us all well. Please contribute to this body of knowledge so that we can take this novel virus into something where we have more experience. Thank you very much and have a good day.